Hello everyone, welcome to today's webinar. My name is Michael and in a few moments I'll be passing you over to Helen to talk about today's subject of transdermal patches. But first, a little bit of housekeeping. This webinar is designed for people with knowledge in giving medicines and is here to help further your role and your understanding. If you do have any questions throughout the webinar, please do ask using the QA feature. We will get to any relevant questions at the end of the presentation. But for now, I'm going to pass you over to Helen to go through today's webinar. Sorry, everyone seems to have some technical difficulties. There we go. Helen, if you would like to take it away, we should be up and running again now.
Okay, thank you, Michael. Sorry to cause you problems. Okay, so thank you all for joining the webinar today. For those of you who don't know me, I've worked at PrimeLife for 4 years and I'm involved in everything medication, including developing new training packages, audits and EMR, and just general advice. Previously to my joining PrimeLife, I worked for several pharmacies supporting care homes all over the country. And I think of myself as a people person. I hope you find today's webinar a really useful support tool. So as Michael introduced a few minutes ago, today we're going to be looking at transdermal patches. And this session has been requested by one of our care homes. We will be covering what is a transdermal patch, why do we use them, how to apply, how to remove and how to document. So, what is a transdermal patch? A transdermal patch is a patch that attaches to your skin and contains medication. The drug from the patch is absorbed into the body over a period of time, and it can help residents who dislike swallowing pills or can't swallow pills or need constant levels of certain medications. Transdermal patches are used to deliver a range of drugs into the body, and some of the drugs often used in patches include fentanyl to relieve pain, rivastigmine for dementia, nicotine to help support with quitting smoking, clonidine to treat high blood pressure, hyoscine hydrobromide, and this is used for travel sickness, sometimes better known as quells, but it's not to be confused with hyoscine biterbromide. I hope I've pronounced that properly. Everol, which is a hormone therapy replacement, and ibuprofen, which is an anti-inflammatory to use to reduce swelling. Overall, transdermal patches are easy to use, but for them to work well, it's important to use them properly. And hopefully this training will be a support tool to you to providing step-by-step instructions on how to apply and how to use them safely. So, patches in detail. Let's have a quick look at the advantages and disadvantages. So, as we said before, a transdermal patch is a medication adhesive patch that is placed onto the skin to deliver a specific dose of medication through the skin and into the bloodstream. Often, this promotes healing to an injured area of the body. An advantage of the transdermal drug delivery route over other types of medications delivery, such as oral or topical, intravenous, intramuscular, etc., is that the patch provides a controlled release of medication into the patient, usually either through a porous membrane covering the reservoir of medication or through body heat, melting the thin layers of the medication embedded in the adhesive. Main disadvantage to transdermal delivery system stems from the fact that the skin is a very effective barrier, and as a result, only medications whose molecules are small enough to penetrate the skin can be delivered by this method. So this slide just shows a wide variety of medications which are now available in transdermal patch form, such as Everol, as we spoke to before, that's used for the menopause. Votrol is an anti-inflammatory, rivastigmine, again for dementia. And then there's travel sickness, pain relief, stopping smoking. There's a whole range of medications now available in patch form. And when we think about transdermal patches, I think we often just think of controlled drug patches like Butec or morphine patches, etc. There's often a question asked of me, do I need to wear gloves when I'm applying a patch to a resident's body? And gloves shouldn't be worn when applying medication patches, as they may stick to the plaster. However, with that said, good infection control still applies. We need to wash our hands before applying the patch. We need to wear the appropriate PPE, and we need to wash hands after applying the patch as well. And also remember not to touch your face, not to get any contact near the eyes, because sometimes the medication can come up into the skin and we rub it into our eyes, and that could be quite a serious injury. As always, before we apply a patch to any of our residents, we must remember to check the SITS rights before we apply. So are we checking that we've got the right person, that it's the right medication, the right patch? Is it the right time? Is it the right dose? Is it the right fuse and right route, sorry, and we've got the right to refuse. One critical thing in the 6 rights that we need to pick up today is it is at the right time, because patches are often given every 72 hours or once weekly, or every other day. There's a variety of times, so it's really important that we read the patient information leaflet, we read the doctor's instructions, and we thoroughly understand that it's the right time for that resident's patch to be applied. Before we apply the patch, we need to check the patch application record or our body chart. So we need to know where the new patch will be placed. We need to follow our doctor's instructions, and the medication label or package should give us information on where to apply it. Again, we should be documenting this on our body maps. For instance, certain patches should be applied to the upper chest or the upper outer arm. Other patches could be placed to the lower abdomen or hip. And again, this should be clearly documented on the patch chart and the MAR chart where the patch is to be applied. I would also recommend that if you're using the EMAR system, that you document where the patch is to be applied on the patch chart, but also document it as a note on the system. As previously said on the last slide, how often should it be applied? Again, patches are applied daily, every 3 days or every week, and it's really important that we make sure that we're applying the patch as directed at the right time. Remember to show this information on the patch application form and document it on the MAR chart. And also, if it is a controlled drugs patch, it needs to be documented in the CD book. Always remember your dignity and respect training when applying patches. Always make sure the resident is comfortable. A little bit more about before applying patches. Read all the instructions that come with your patch. The instructions will tell you where to place the patch, how long it needs to be applied for, and when to remove or replace it. Remember, you can always refer to the patient information leaflet inside the box, the BNF or the MEC for further information. Again, remember to check how often does a new patch need to be applied. Weekly, daily, every 3 days or every 72 hours. Take care to check this and check this again. Document this on the MAR chart and the patch application form. Just a point to remember, if the instruction is applied every 72 hours, we must document the application time on the MAR chart or on the EMAR system. 72 hours is not always 3 days. Okay, so if it's always applied at 8 o'clock in the morning, it would always be applied 72 hours later from that 8 o'clock time. So, ready to apply. So first of all, we prepare the skin to remove any dirt, lotions, oils or powders. We clean the skin thoroughly using warm water alone or with a clear soap. We must avoid scented soaps or soaps that contain lotion, and then we dry the skin with a clean towel or a paper towel. Check that any old patches have been removed, and we will be discussing on how to destroy the patch later. It is important to check the body because sometimes a patch can come loose and be moved to a different area. Very rarely, but this could happen. Open the package carefully by tearing it open or using scissors. Avoid tearing or cutting the patch itself. If you do tear or cut the patch, then don't use it. Throw away the damaged patch as directed, and remember it will still contain some of the drug. Take the patch out of the packaging, removing the protective liner on the patch as directed by the patch instructions, and be careful not to touch the sticky side of the patch. If the patch's protective liner contains two parts, first peel off one part of the liner, apply the exposed sticky part to the patch to the skin and press down. Next, peel back the second part of the liner and press the entire patch down. Apply patch by holding one hand firmly over the patch for 10 seconds, then press around the edges to make sure that the patch is securely attached to the skin. This helps prevent loss of the patch and ensures effectiveness of medication delivery. Do not apply a new patch to a previously used patch site for at least 1 week, so the skin, skin irritation is reduced. When applying a patch, remember, choose a spot where the patch will attach well. Remember to avoid skin that has open cuts or sores, creases, sweaty areas, where the skin is rubbed frequently, hairy areas of the body, and if the body or part of the body has been recently shaved, must wait at least 3 days after shaving before applying a patch to that area. Remember, if it's covered by a belt or clothing seam, this could again cause irritation. Use the patch once only. Never cut or divide the patch. Keep in mind that the skin isn't the same everywhere over the body. Be sure to place the patch according to the instructions from your doctor or on the instructions on the package. Placing the patch on skin that's too thin or too thick could cause your body to absorb too much or too little of the drug, and this could lead to increased side effects or prevent the drug from working well. Your doctor may suggest that you rotate the locations where to apply your patch. This is because placing a new patch in the same place as the old one may often irritate the resident's skin. When rotating patches, stay in the same area of the body. For instance, if you're told to use the patch only onto the hips and the lower abdomen, rotate the patch locations within those areas. If you're using more than one patch at a time, never overlap them and don't place one patch on top of another. The entire sticky side needs to be in direct contact with the skin. Never apply a heating pad over a patch, as this will affect the rate of absorption with potentially serious side effects. Removal of patches. Check that the old patch on the resident that contains the same drug has been removed. If we don't do this, this can cause an overdose. Do this by peeling back the edge of the patch with your fingers and then gently pulling off the rest of the patch. Fold the patch in half with the sticky sides pressed together and throw away the used folded patch. This can be disposed of in the normal waste, as all of the drug has been absorbed. Remember, if the patch falls off, this needs to be returned in the doom kit or returned to the pharmacy, as it will still contain some of the active medication. Please remember your medication training on returning medications, and if it is a CD patch, then it is best to return them on a single page of the CD book if you're still using the paper system. So what happens if the patch loosens or falls off? Refer to the doctor's instructions or the label instructions. In general, for a loose patch, you can usually use the palm of your hand to press the patch back onto the skin. Dispose of the patch correctly, as it could still have some of the drug in place. Contact your GP and ask for advice on applying a new patch. If one edge of the patch becomes loose, use tape or sticky adhesive film to secure the loose edge. If the patch falls off completely, don't try to reapply it. Throw it away and apply a patch at your next scheduled time. It is important to make sure the patch remains secure. A loose patch can adhere to other individuals to whom you're in close contact with, or it can end up stuck onto the bed sheets or bed clothing. Never soak the patch. Feel free to shower and get the patch wet. However, don't keep the patch under water for long periods of time, as this can cause it to loosen or fall off. Here is an example of the patch chart, and again this tells us what is the duration of use, the interval before reusing a site, the number of sites on rotation. It also gives us the name of the patch, the strength, the resident's name, and we've got images here of where we can apply the patch, the date it was applied by, the date and the patch was removed, who removed it, and if it was a CD patch, again, who was it witnessed by. This is a really useful patch chart because it gives all the information on there. And sometimes our residents will refuse to take their medication. It could be because the medication is hard to swallow, tastes unpleasant, or causes side effects such as loose stools or constipation. Or in this case, it could be that it causes a rash, or it's very discomforting for them when you're applying or reapplying the patches. You can usually tell from the person's reaction that they dislike the taste or that the drugs can cause unpleasant side effects. Contact the GP for advice on alternatives, and this could be where a patch could be prescribed. There are times when a person is more comfortable taking their medication in a particular setting or with the help of a certain member of staff. Always think about your dignity and respect training when administering medications or applying patches to your residents. If the resident refuses this medication, we can offer the medication later, but this must be documented with the exact time on the MAR chart and does not apply to time-critical medications. But remember, the resident has the right to refuse. So if a patch is to be applied every 72 hours, then it needs to be applied every 72 hours. We can't leave it later. It is important to remember to document on the reverse of the MAR chart any results or outcomes, and if the medication is a PRN or when required medication. Obviously, this doesn't apply to patches, but try not to be tempted to hide medication in food. Medication hidden in food is called covert medication and needs to be approved and have written consent in place. This should be documented in the care plan and documented on the MAR chart. Again, think about your MCA and DOLS training when applying and administrating medications. Does the person have capacity to refuse to take their medication? If they refuse, try again later. Remember to document and report all non-administered medications and inform the manager. If the medication is refused throughout the day, talk calmly to the resident, explaining the importance of taking the patch and how it will help them before documenting it as being refused. Remember, documenting all non-administered medications on the MAR chart is just as important as documenting when a medication is given. This information could be important later. Always remember to wash your hands before and after administering any medications and use the appropriate PPE. Remember to clean the medication trolley before and after each medication round, replenishing the mediparts, the giving spoons and the syringes. Think about your infection control training when administering the medications. All medications have side effects, including patches. And to find out more about medication, check the patient information leaflet in the medication box, or if you have a BNF book, or look on the EMC website or online for side effects, dosage information and overall advice. Remember to monitor the resident for any changes or reactions that may be caused by the medication and report your concerns to your manager. Always check the patient information leaflet, which is often known as a PIL, in the medication box or the BNF book or the EMC online for all side effects and medication advice. Always inform the supplying doctor or pharmacist if the resident is taking any other medications, including herbal medications, vitamins and supplements, or cold and flu preparations. And remember, if a resident has any allergies, this must be documented on the MAR chart. Do we have any other questions today, Michael?
Okay, we've got a couple. First question. By using the patches, is there a higher or lower risk of having any reactions?
Okay, so by using patches, there tends to be a lower impact on adverse reactions because that patches is directed on that site. So there's a lower impact on adverse reactions. Okay,
perfect. Is that why they're often recommended over other medications?
Yes.
Yeah.
Yes, it can be. It can be. Yeah, that could be one of the reasons. And because you're changing the site as well, it's not always going on the same part of the body.
Okay, that makes sense. If the patch is prescribed for pain relief, how long will it be before the resident feels any benefits from the patch?
Okay, so patches, tend to be that the drug is absorbed slowly into the body, so it's more of a controlled release. So you're not going to get a quick response from that medication. It could take 12 to 24 hours to reach its peak, maybe. And then sometimes, dependent on the actual patch we're talking about, the effects of that patch can last up to 12, 17 hours after we've removed it. What I would say that if they needed a quick breakthrough pain relief, then to use another painkiller first of all. So if they're in pain first of all before applying the patch, then give them a fast-acting pain relief first.
Okay, perfect. Last question. Can a resident have more than one strength of patches dispensed?
Yes, they can. We often have a lot of our residents have different strength of patches. It would depend on the amount of pain control that they need to take and how much is the body is going to absorb. Yeah, so yeah, they can have more than one patch, but it would depend on the amount of the total amount of pain relief that they actually need.
Would that be something they need to talk to their doctor about then, just to make sure that they're not got too many going on at the same time and that sort of thing?
Yeah, that you would. Yeah, absolutely. I mean, mostly it is for pain relief. The transdermal patch that is for pain relief. You probably have a 5 milligram and a 10 milligram. Again, putting on different areas. The most important thing is that we don't put one on top of the other. and we still rotate, the sides, and even not just putting them one on top of the other, but we don't place them sort of touching each other either, you know, overlapping. They need to be put on separately. But yes, residents can have more than one strength of a patch prescribed for them.
Well, perfect. And I think that's all the questions for today. So, Helen, thank you very much for your time. If they have got any more questions, how can they reach you?
Yeah, anybody can just give me a call on the phone. My telephone number is 0791 704 5483. Or you can just email me at helenberridge@prime-life.co.uk.
Perfect. And thank you again, everybody, for watching today. We will see you in about 2 weeks' time for our next presentation.
Thanks, everyone, and thank you, Michael. Take care. Bye.
Bye.